I'm Professor Andrew Coates. I'm President-elect of the Heart Failure Association and heart failure cardiologist from the UK. It's been a very exciting congress here in Athens for the Heart Failure Association 2019. We've had nearly 5,500 delegates, multiple posters, presentations, a lot of industry exhibits, and some late-breaking clinical trials that are really, I think, going to show a different way of treating heart failure in the future. I think the themes I've seen in this meeting are a much greater interest in devices and how devices can integrate to drug treatment, an interest in technology-assisted medicine, quite an expanding interest in digital health and solutions, but also an appreciation we have to get the care of medicine right. We have to have multidisciplinary teams, and we have to know how to integrate our care so the patient just doesn't fall between different doctors, but we have a joined-up system to make sure that their heart failure is managed well in the long term. Heart failure is not just a disease you get and then get cured. It's a chronic disorder that if we manage well, we can keep under control and we can improve the outcomes of patients through the application of what we already know, as well as getting new information in the future. In this Heart Failure Association meeting, we've had a number of late-breaking trials. Obviously, I haven't had a chance to go to them all, but the ones I've attended have suggested there really is continuing innovation in device-based management of heart failure. Just today, we heard from the PHARM-CHF trial, which is a baroreflex stimulation, and it's the first that's showing some realization of the benefits or the potential benefits of autonomic function modulation. So what we've seen in an earlier trial, HFA, is that if you stimulate the baroreflex, it can improve exercise tolerance and patient quality of life and well-being. That's now been supplemented, and it's showing that you can get these benefits, and potentially it might add up to benefits in terms of protecting patients from heart failure hospitalizations in the future. I can't say we've got to that last bit yet, but certainly we've got something I think is approvable and may well become available for patients in the not too distant future. We've also seen further evidence for a treatment that's a little bit further advanced, so-called cardiac contractility modulation, or CCM. So that's had a confirmatory study called HFA, which used a not so commonly used but very well accepted methodology of Bayesian statistics, borrowing 30% of data from previous trials and then an FDA approved protocol showing that these results could be duplicated and supported. That's led to an approval and in sales of this device both in the US and in Europe, and a commitment from the manufacturer to do an outcomes trial so we can really look in the long term at the effects of mortality and hospitalizations. CCM fills a gap in what's available because it's an electrical stimulation applied to the heart. It stimulates the cardiac myocytes during their absolute refractory period, and that leads to gene alterations in terms of how they're expressed in a beneficial way, and leads to increased contractility and beneficial left ventricular reverse remodeling. As I said, that's been associated with very consistent improvements in exercise tolerance measured by peak VO2, and we're now seeing trends and suggestive benefit in terms of fewer hospitalizations for heart failure in the future. So I think this is one of the new treatments, but as I said before, it's targeted at a group that so far hasn't had a device treatment available because it's for narrow QRS duration. It does appear to be best in the ejection fraction range between 25 and 45%. So it's not for extremely severe heart failure, but I think it's a useful addition for the future in heart failure. What we've also seen in this meeting is an increased interest in comorbidities. I've just come from a session on sleep disordered breathing, and this really was a packed audience room. People are very interested in this very common abnormality. 2/3 of our patients with heart failure are sleep disordered breathing. It's not all obstructive, probably the most common is central sleep apnea, and we do need to look at this more carefully because in the presence of such central sleep apnea, which is usually a Cheyne-Stokes respiration type, we do see exaggerated risk of mortality, heart failure hospitalizations, and particularly sudden death. What's very fascinating is that a treatment we thought would be highly likely to be beneficial, that of positive pressure airway mask, ASV type, that actually was associated with an increased cardiovascular mortality. So we've had to put that aside, and we no longer can recommend that. In fact, we recommend that no patient with heart failure and predominantly central type sleep apnea should have positive pressure airway mask therapy. But there is a novel treatment that's out there that has been evaluated, and that's a phrenic nerve stimulator, an implantable device called the Remedy system, and that's been associated with an improvement of sleep quality, an improvement in the central sleep apnea itself, and it's associated with a significant spatial global assessment in favour of the treatment. It improves all the parameters of sleep quality, improves daytime sleepiness, and seems to be associated with the improved heart failure related quality of life. Like some of the other treatments, it's not definitively shown in terms of death and hospitalizations, but the data to date suggests that there may well be a protection from repeat hospitalizations. But yet again, that's only a hypothesis generating. We need larger trials to prove that in the future, although well-constructed prospective registries are underway, so we will get further information in the near future.